The next solid tumor I am going to discuss about is neuroblastoma. Certain facts about neuroblastoma which you should know are: it is the most common intra-abdominal tumor in children. Second important point to be noted is it is also the most common extracranial solid tumor in children. Please remember, overall most common solid tumor in children is the intracranial or the brain tumors. Second most common solid tumor in children is neuroblastoma. Okay, and this neuroblastoma usually occurs in young children in infancy, and it is considered as the most common malignancy noted in infancy. Okay, what is the cell of origin of this tumor? As the name suggests, it is neuroblast, which are derived from neural crest. That is the origin of this particular tumor. Talking about where this tumor is present or the site of involvement, please remember the most common location is in the adrenal gland. Okay, that is the overall most common location of this tumor. Okay, we can also call it as suprarenal tumor because it is above the kidney. Okay, the second important site, the second most common site is related to the paravertebral sympathetic chain. We all know that there is a sympathetic plexus surrounding the vertebral column. In that region, any place can be affected. So that is called as paravertebral sympathetic area, or I will also call it as paravertebral sympathetic ganglion area. Okay, that is the next common site of involvement. The next common area is in the posterior mediastinum, where it can present as a mediastinal mass. And the next common area is in the pelvis. These are the common areas of neuroblastoma, but overall most common site is adrenal gland. Now let's have a basic look at the pathology in neuroblastoma. It is a solid tumor, and if you take biopsy from the tumor, what you will notice is a collection of small round blue pattern of cells. It is nothing but uniformly you get blue cells. Okay, and these blue cells are so called because they have a scanty cytoplasm. Along with that, they also have a dense or hyperchromatic nuclei. Okay, that is why it is called as small round blue cell tumor. Please remember, small round blue cell tumors are not diagnostic for neuroblastoma. There are other tumors also where you get this small round blue cell pattern. What are they? Non-Hodgkin's lymphoma, you get this pattern. Rhabdomyosarcoma, you get this pattern. And also in Ewing's tumor, you get the same pattern. So this is a common pattern noted with many tumors, not only neuroblastoma. Okay, next important thing in pathology, if you look at the individual cells, they have an appearance like this. What I am trying to draw here, it is something like a petals, okay, or rose petals. These are the tumor cells which form like a petals of a rose. So it's called rose petal appearance. And this appearance is also called as a rosette appearance. Okay, and in the center of the petal, you will get some eosinophilic material like this. Okay, which is also called as a neuropil. Okay, neuropil is something like the cytoplasmic processes. Okay, or what we also call it as neurites. So in the center, you have a collection of neuropils surrounded by petal of tumor cells. This is also called as the Homer-Wright rosette. The name of this rosette is Homer-Wright rosette. This is the diagrammatic representation of the Homer-Wright rosette, which I have just discussed. Okay, so that is about the pathological findings in case of neuroblastoma. Now moving on to clinical features of neuroblastoma. Please remember that this is an abdominal tumor, so it can present as an abdominal mass. Okay, the classical description of abdominal mass associated with neuroblastoma is that it is a firm, fixed mass with an irregular outline. Okay, that is a classical description of the abdominal mass in neuroblastoma, and it is usually a midline mass. That is also another important point for this tumor. Okay, the next set of presentation would be constitutional symptoms, and these constitutional symptoms include the usual one which we have discussed in other tumors also. What are they? Fever, weight loss, as well as there could be irritability. These are the constitutional symptoms in neuroblastoma. Okay, so abdominal mass and constitutional symptoms are the usual presenting features. Sometimes they can also have other features, which includes Horner's syndrome. This is due to involvement of the sympathetic chain, where the child will have classical features. What are they? You must have studied Horner's syndrome in other conditions also. So you must be knowing the features. What are the features? Yes, it is anhidrosis. It is anhidrosis, meiosis, as well as ptosis. These are the classical features of Horner's syndrome. Next important feature is heterochromia iris, where you can remember from the name itself, there is difference in the color. Hetero means different, chromia means color. So different color of both the iris. That is also a feature noted in some cases of neuroblastoma. These are the usual presenting features of neuroblastoma. Some of the cases can present not with the primary tumor itself. Instead, they can present with metastasis. And the most common site of metastasis in neuroblastoma happens to be the bone. So, they present typically with bony pain. For example, if the bones in the limbs are affected, child will not move the limbs at all due to severe pain associated in this condition. So, bone pain is a usual presentation. Next set of manifestation is due to metastasis to the retroorbital areas, that is backside of the orbit, where there will be infiltration or metastasis, and it typically presents like this. What is this? Yes, can you notice that there is a periorbital swelling? Along with that, you see the discoloration, which is due to ecchymosis. Okay, please note it is due to retroorbital metastasis, and the name of this condition is called as a raccoon eyes. Okay, right. That is another important presentation which you should know. The other set of presentation is related to metastasis in the skin, where you can have lesions like this, which are purplish or bluish subcutaneous nodules, like what you are seeing in the picture, and this is called as blueberry muffin lesions. Very, very important finding. Blueberry muffin lesions. So remember, a case of neuroblastoma may not present due to the tumor itself. It may sometimes present with metastasis. And even more, in some cases, they can have paraneoplastic manifestations as a presentation. And there are some characteristic paraneoplastic syndromes associated, which I want you to remember. First is a condition wherein the child's eyes will not be in one position. They will be constantly moving around, something like a nystagmus. Okay. Second is there will be irregular jerky movements of the limbs also. And third is when the child is standing or walking, they're not able to maintain a steady posture. Or in other words, there is associated ataxia. Putting all these together, you get the classical finding called as opsoclonus, myoclonus ataxia. Very, very classical finding, which is a paraneoplastic manifestation in this condition. Okay. And because eyes and feet are commonly affected, this condition is also called as a dancing eye or dancing feet syndrome. Okay. This is a very common paraneoplastic syndrome, and it is usually related to the presence of anti-neuronal antibodies. Okay, that is the reason which is put forth for opsoclonus myoclonus ataxia. Next condition is due to increased secretion of vasoactive intestinal polypeptide, okay, VIP hypersecretion. And because of this vasoactive intestinal polypeptide, the common features which are noted include intractable watery diarrhea as well as hypokalemia. Okay, so this is the second paraneoplastic syndrome associated with neuroblastoma. Okay, so remember, either the tumor or metastatic lesion or paraneoplastic manifestations are usual presenting features in neuroblastoma. Now coming to how to investigate a case of neuroblastoma, remember we can do some initial investigation and diagnostic investigations. The initial investigation would be to look for markers in the urine, and the common markers are urinary catecholamine. Okay, basically these are tumors which are derived from the neural crest, so they secrete a lot of catecholamine, the metabolites of which are excreted in the urine, and we can measure them. The commonly used markers include urinary VMA. What is that? Vanillyl mandelic acid. And one more is HVA. What is that? Homovanillic acid. Okay, right. Now please remember, these are not specific for neuroblastoma. They can be elevated in other neural crest tumors also, like in pheochromocytoma. So if they ask you the question, what is the specific marker for neuroblastoma, your answer is going to be estimation of the levels of NSE. What is that? It is neuron specific enolase. That is a specific marker in neuroblastoma, which should always be remembered. Okay. The next set of investigation are the diagnostic investigation, which are obviously imaging studies. Okay. And the commonly used imaging study is the CT of the abdomen. Okay. And the characteristic finding of the tumor on CT is the presence of calcifications. Okay. This is typically described as stippled calcifications. This is a very, very important finding, often asked as MCQs in your exams. Second important finding in the CT abdomen is the tumor, which is a mass noted in the CT abdomen, will displace the kidney infralaterally. This is very, very important point to distinguish from a tumor arising from inside the kidney like Wilms tumor. Okay, so that is why this point is important differentiating point whenever we do the CT imaging of neuroblastoma. Okay, right. The next imaging investigation which you can do is to look for metastasis associated with neuroblastoma. This includes investigations like radionuclide scanning, and the usual radionuclide scanning for this purpose is iodine 123 MIBG scan, which is an expansion for meta-iodo-benzyl guanidine. That is what is the expansion for MIBG, which is very useful for detecting the metastasis. Another useful investigation for detecting metastasis is the PET-CT scanning. Okay, these are the usual investigation which you have to do in a patient with neuroblastoma. Okay, next moving on to staging of neuroblastoma. It is given by INSS or International Neuroblastoma Staging System. Okay, it is divided into 4 stages. First stage is the stage 1, which is characterized by a completely resectable tumors. The next is stage 2, which is characterized by incompletely resectable tumors. Now, This stage 2 is divided into 2A and 2B. Okay, 2A and 2B. 2A refers to a condition with incompletely resectable tumors. However, there is no lymph node involvement. LN is a lymph node. So, absence of lymph node involvement is 2A. With lymph node involvement, it is called as 2B. However, please remember, I am talking about ipsilateral lymph nodes. That is lymph node involvement on the same side of the tumor. Then it is called as 2B. Next, we have stage 3, which is a tumor which crosses the midline. That means goes to the other side, crosses the midline, or unilateral tumor that is only on one side but with contralateral lymph node involvement. Okay, contralateral lymph node involvement. Then it is called as stage 3. So basically, stage 3 refers to either the tumor which has spread to the other side or metastasis has spread to the other side of lymph nodes. That is what is called stage 3. Then stage 4. This is characterized by widespread lesions or disseminated tumors. It is nothing but widespread metastasis to the bone, skin and all those areas. That is called stage 4. Now here I want you to remember one thing called as a special type here. Special type is something called as a stage 4S. Okay, stage 4S. It refers to a tumor which is stage 1 tumor or a stage 2 tumor with dissemination to bone, liver or the skin and noted in an infant. That is a keyword, noted in an infant. That means a child which is less than 1 year. You notice this type of tumor, it is called as stage 4S. The importance of this is because stage 4S has got a good outcome. Because when you read stage 4, disseminated, we always think it's got a worse outcome, right? That is true for stage 4. But stage 4S is also a disseminated, limited dissemination to the bone, liver and to the skin and involves infancy. That is children less than 1 year, and that will always have a good outcome. So don't forget this important point, that is 4S is associated with good prognosis. Okay, right. So now coming to the treatment. Before we go to the treatment, you should do something called risk stratification in neuroblastoma. We can divide these lesions into low risk lesions and high risk lesions. Basically, there will be a slight difference in the treatment, like I have said in other tumors also. So here again I am going to tell the same thing. Low risk lesions are lesions which are in stage 1 or stage 2 or stage 4S. I have said it's a special stage, or a child who is having age at onset less than 18 months. Age at onset less than 18 months. And along with that, some genetic factors also. Genetic factors basically includes some genetic condition which has got a good prognosis or classified as a low risk. These are all MCQ questions for you. One is the hyperdiploidy. Next important is TRKA gene expression. These are two important genetic factors which have a good outcome or a classified as a low risk condition. Next is the high risk lesion, which refers to the other things like stage 3 or stage 4, age at onset after 18 months of age, and finally again some genetic factors. And these genetic factors include hypodiploidy. Okay. Second is NMYC gene amplification, and third important is LOH. What is that? Loss of heterozygosity of certain locations of the chromosomes, which include 1p and 11q, that is short arm of chromosome 1 and long arm of chromosome 11. These are basically genetic factors associated with the poor outcome, so classified as high risk lesions. Now coming to the treatment, we divide it into treatment for localized cases, that means cases which are low risk and without metastasis, and disseminated cases. Okay. For localized disease, the treatment is usually surgical resection of the tumor. That is all that is required for localized tumor. If it is a disseminated tumor, then along with the surgery, you also have to add chemotherapy. The chemotherapeutic agents include cisplatin, cyclophosphamide, vincristine, and etoposide. Sometimes patients may not respond to surgery and chemotherapy alone. For them, you have to add radiotherapy also. And cases which are not responding to radiotherapy also, you may have to go for a final treatment option, which could be autologous hematopoietic stem cell transplantation. That is what is HSCT. In cases which are not responding to surgery, chemotherapy as well as radiotherapy, we call them as refractory cases. These cases may respond to stem cell transplantation. What is that? Autologous HSCT, which is hematopoietic stem cell transplantation. That could be the treatment option for these patients. So that is about the discussion of neuroblastoma. The next solid tumor again involves the abdomen, and that is called as Wilms tumor. Please remember that Wilms tumor is a tumor related to the kidney. So that is why the other name of this condition is also called as nephroblastoma. Nephro refers to the kidney. And it is the most common solid tumor of kidney in the childhood. I told that Wilms tumor is an intra-abdominal tumor. However, it is the second commonest intra-abdominal tumor. The first common intra-abdominal tumor is a topic which I discussed before, and that is Wilms tumor. These are all one-liners which are commonly asked in the exam, so you should definitely make a note of it. Talking about cell of origin of Wilms tumor, remember the name nephroblastoma. Blast refers to the premature forms of the cells. Okay, here it is the premature forms of renal cells, or in other words, it is derived from something called as a primitive structures in the kidney, which is due to undifferentiated mesenchyme of the kidney. Undifferentiated mesenchymal cells of the kidney, what is called by the name of nephrogenic rest. This is an important point to be noted. If they ask you the cell of origin, it is nephrogenic rest. That is the answer which you need to remember. It's a commonly asked question also. Okay, next moving on to certain basic facts about Wilms tumor. The age group affected is 2 to 5 years. Remember, for neuroblastoma, I said it is in infancy it usually manifests, whereas Wilms tumor is after infancy. That is why the range of 2 to 5 years. And Wilms tumor mostly is a unilateral tumor. Some of the important associations or risk factors for development of Wilms tumor that you should know about. Okay. One is the renal malformations. We were talking about some renal malformations in the modules on renal system. There I mentioned one of the important risk factor is horseshoe kidney. If you can recollect, I have said in my lecture, that horseshoe kidney confers a 4-fold increased risk of Wilms tumor when compared to general population, and this is a usually asked exam question. Okay, right. Second important malformation which is associated is cryptorchidism, undescended testis. And third important malformation is hypospadias. Okay, right. The second important set of associations for Wilms tumor is some genetic syndromes. Okay, and genetic syndromes I'm going to discuss with the help of some gene names. And in that there are two gene names. One is WT1 gene, other is WT2 gene. WT you can simply remember as Wilms tumor. Okay, WT1 gene is located to the short arm of the chromosome 11, which is what I've written as 11p13. And there are some important genetic syndromes associated. First is called as a Wager syndrome, WAGR syndrome. This is an expansion wherein each alphabet corresponds to some manifestation. For example, W stands for Wilms tumor, A stands for aniridia, G stands for genitourinary anomalies, and R stands for retardation, which is growth retardation. This is the expansion of Wager, which is the first example of genetic syndrome associated with WT1 gene. Next important association for WT1 gene is Denys-Drash syndrome. This is a condition which is characterized by diffuse mesangial sclerosis in the kidney. Diffuse mesangial sclerosis. And this condition usually presents as congenital nephrotic syndrome. Congenital form of nephrotic syndrome. And second important feature of this syndrome is it is associated with ambiguous genitalia in males. Ambiguous genitalia in males. That is about Denys-Drash syndrome, which is a second example of gene defect associated with WT1 gene. Next is about WT2 gene defects, which is located to, again, short arm of chromosome 11, but at a different location. You see here what I have written, it is 11p15. And the name of the condition is Beckwith-Wiedemann syndrome. If you can recollect, I have discussed this Beckwith-Wiedemann syndrome in the modules of neonatology also. What is that? It is characterized by a LGA baby with hemihypertrophy. That is, one side of the body is bigger in size. Can you notice from this picture? This is a baby with Beckwith-Wiedemann syndrome. You can see that the limbs on the left side, this is the left side. You can see that the limbs on the left side are bigger in size compared to the right side. This is what is hemihypertrophy. Okay. Next important point is macroglossia. They can have omphalocele, which is an abdominal defects, omphalocele, abdominal wall defects at the region of umbilicus, omphalocele. They can also have organomegaly, like liver and spleen can be enlarged. And typically, when you examine these patients, you will notice small creases in the earlobe creases. These are the characteristic features of Beckwith-Wiedemann syndrome, yet another genetic syndrome associated with increased risk of Wilms tumor. Now, moving on to features of Wilms tumor. Please remember, Wilms tumor causes enlargement of the kidney, thereby they present as abdominal mass. Very, very important. Abdominal mass. Which part of the abdomen? It is in the posterior part of the abdomen, in the loin area, because that is the location of the kidney. That is how they usually present. Okay. However, remember, other than abdominal mass, in the initial stages, they don't have any symptoms. So it is usually an asymptomatic abdominal mass, which is a presenting feature of Wilms tumor. Okay. The other feature would be related to increased production of renin. And this is attributed to the development of hypertension in the affected children. So you see a young child with unexplained hypertension. One of the differential which you have to keep in mind is Wilms tumor. They can also present with hematuria as a manifestation. Okay, these are the usual presenting features. The other set of features may be related to the metastasis. Okay, please remember the common sites of metastasis are remembered by the alphabet L. What are they? Lungs. Lungs are the most common site of metastasis. This has to be remembered very clearly because the previous tumor, that is neuroblastoma, what is the most common site of metastasis? I said there it is bone, but in Wilms tumor it is a lungs. That is number 1 site. Number 2, L is for the lymph nodes, and third L is for the liver. These are the usual sites of metastasis in case of Wilms tumor. Now we come to the staging of Wilms tumor, which is called as COG staging, which is Children Oncology Group staging. Now, very important, there are 5 stages in this staging system, and staging is done after surgery is done. Very, very important. So, once the diagnosis of Wilms tumor is made, you take up the child for surgery, and then after surgery is completed, you do the staging. That is an important point. Okay. So, what is stage 1? Stage 1 is a tumor which is limited or confined only to the kidney region, and it is completely resectable. Okay, right. Stage 2 is characterized by a tumor that extends outside the kidney margins. However, it is completely resectable. And in this stage, usually lymph nodes are not involved. That is what is stage 2. Stage 3 means there is residual tumor after surgery. Residual tumor after surgery. That means even after you have done the surgical resection, the margins of that resected area still show tumor lesions. Then it is stage 3. And in this particular condition, the tumor is confined to the abdomen. So, it extends outside the kidney but confined to the abdomen. Okay, that is what is stage 3. Stage 3 also refers to presence of regional lymph node metastasis. That is involvement of the lymph nodes in the abdomen only. Then it is called regional lymph node metastasis, stage 3. It also includes tumor extension into inferior vena cava. Okay, into IVC. That is also included under stage 3. Now, stage 4 is characterized by lymph node metastasis outside abdomen, outside the abdominal cavity. That is stage 4. And stage 4 also refers to hematogenous metastasis, which includes metastasis to the organs like the lung and the liver. That is what is stage 4. And stage 5 refers to a condition where both the kidneys are affected. Bilateral kidney involvement is stage 5. This is what is the staging system called as Children Oncology Group staging system for Wilms tumor. Next, I am going to describe about the treatment of Wilms tumor. Remember, in all patients with Wilms tumor, you have to do nephrectomy. Now, this nephrectomy has to be a radical nephrectomy or a partial nephrectomy. Partial nephrectomy is advised in bilateral tumors because it is not possible for you to remove both the kidneys completely, right? Unless you have a ready donor for kidney transplant, it is usually not done. So that is why bilateral cases you do only partial nephrectomy. In all other conditions, you are going to do radical nephrectomy. So essentially, stage 5, where bilateral kidney involvement is there, you do partial nephrectomy on both the sides, whereas all other stages, you are going to do radical nephrectomy. Okay? And further treatment is decided by the stages. In stage 1 or 2, you are going to add chemotherapy with vincristine and actinomycin D or actinomycin for a period of 18 weeks. Okay. Whereas in stage 3 or 4, in addition to vincristine and actinomycin D, you also have to intensify the treatment by adding another drug, which is doxorubicin. And this total duration of treatment here will be 24 weeks. Okay. And all patients in stage 3 and stage 4, they will require radiation therapy also. In stage 5, as I have already said, you do partial nephrectomy. In addition to partial nephrectomy, all the chemotherapeutic drugs which I have mentioned should be added, and they also require radiotherapy. This is the treatment outline for a patient with Wilms tumor. So that completes our discussion of solid tumors in children.